across my room as I wake from another dream of you. You be staring at me, giving me a kiss, say honey, play me a song, sip a melody. You be something who say, oh, obey me. Wait, you came along when I was nobody, nobody. Then show me how to be somebody, somebody. Hey, you ever heard about she fell? Oh, I go die with you, get a bad boy. Feel so bad, say, whoa, my love, my love, my love. You bring out the best in me. You bring out the best in me. You bring out the best in me. Oh, yeah, the touch of your hand. You bring out the best in me. Gotta let them know you're my man. Oh, you're my man. You bring out the best in me. You bring out the best in me. You bring out the best in me. You bring out the best in me.
Joy 99.7 FM.
Of your hand, you bring out the best in me. Gotta let them know you're my man. You bring out the best in me. So every second, every minute, every hour.
Joy 99.7 FM.
You give me the strength to accept the things I cannot change. Intentionality, I'm a different move. Baby, I'm not here, now you're true. Me go cry, go. You came along when I was nobody, baby. Then show me how to be somebody. Oh, now he never heard about she fell. I go die with you, give a bad boy. He said, oh, yeah, and sister, oh, my love, my love, my love.
That's right, and it's always good to be here.
Bring out the best.
9 minutes past 2 on Joy 99.7. Slightly late start. Let's get into it, and we have got the best in the studio. Yeah, today, I'm honored to celebrate Ghana's own. Let me say Ghana's own, Yeah, he just recently done his inaugural lecture, professorial lecture. Professor Vincent Boima. He's a professor in medicine and nephrology. We'll learn a bit about that. But indeed, his inaugural lecture touched on, lighting the way, breaking new frontiers when it comes to comprehensive precision kidney care in Africa, not just Ghana, in Africa. And I have the honor today of, hosting him and, going through that paper and trying to understand what he's saying and the import for kidney care indeed in Ghana. He shared some of the statistics when it comes to chronic kidney disease in Ghana, and we'll be talking about some of that. And more importantly, some of his findings. Yes, there are genetic underpinnings for kidney disease, and the study has also, should I say, confirmed the location or the geoplacement of some of these genetic biomarkers for kidney disease. So, ladies and gentlemen, my guest today, Professor Vincent Boima, not a stranger to the studio. Prof, welcome.
Thank you very much, and then good afternoon to your listeners.
It's been a while. Indeed, the last time we had you on Ultimate Health, we are again celebrating. We were celebrating the 60th anniversary of the University of Ghana Medical School.
Yes.
Right. But today I want to celebrate you. First and foremost, Ayeko, congratulations.
Thank you very much. Thank you.
Full professorship in medicine and therapeutics. What does really that mean for our listeners?
So it really points to what we call internal medicine, how physicians take care of the patient in terms of diagnosis and giving treatment. The treatment is the therapeutic aspect of it. So you take the patient through a set procedure, arrive at the possible diagnosis, and then investigate the patient and offer treatment. Mm-hmm. And the treatment could be in the form of advice on healthy lifestyle plus medications that we give. and that is the therapeutic aspect of the medicine that we are
Medicine.
talking about.
Right.
Yes.
Okay. And then the nephrology for my listeners.
Nephrology has to do with the study or diseases with things related to the kidney.
Right.
So people who are called nephrologists are specialists in kidney diseases, kidney and its related diseases.
Okay.
That's literally what it means. Yes.
Okay. And now you're a full professor in that, and also head of medicine and therapeutics
Yes.
in Kolebu or with the medical school.
With the medical.
With the
school.
medical school.
Yes.
Okay. So that's a mean feat. And on the 17th, you delivered your inaugural
On the
lecture.
14th.
14th, rather.
Yes.
You
please.
delivered your inaugural lecture.
At the University of Ghana. Yes.
Right.
Yes.
And I love the title, right? Share
Yes.
with us, because it encompasses the genetic or the biological.
Yes.
You also talk about the mind, and
Yes.
then you look forward at the implications of the findings.
So I said from genes to mind, the holistic care for patients with kidney disease in Africa.
Okay.
So it talks about genes that increase our risk of developing kidney disease.
Okay.
It also talks about how chronic illnesses, including the kidney, affects the mind.
The mind.
Yes.
Okay. So, folks, genes that, relate to and may predict or do predict kidney disease. Okay. And there's an earlier study that had been done way back. And you've done, shall I say, a progression of this study. And you've been able to
Precisely.
replicate across, is it Ghana and Nigeria?
Current, yes.
Right.
Absolutely.
The
Yes.
presence of this gene
Mhm.
that, can I use the word causes
that
or is
increase
related?
our risk of developing kidney disease.
Right.
Yes.
Right. So there's a genetic marker
Mhm.
which, if you have,
Mhm.
increases the risk that you may
Develop kidney disease.
develop kidney disease. Okay. Now, interesting in this study, of course, is that from where it was initially done, there's been tracing down to our continent
Yes.
and indeed our sub-region,
Right.
and that this gene or genetic biomarker for
Mhm.
kidney disease, and can I use the word prevalent in
You can
sub-
say that, yes.
West Africa?
West Africa, yes.
Yeah.
So you can say that. So often times we actually attribute chronic kidney disease to non-communicable diseases such as hypertension,
Mm-hmm.
diabetes, chronic inflammation in the kidney, what we call chronic glomerulonephritis.
Yeah.
And then also infections like hepatitis B, C, and HIV,
Right.
and exposure to environmental factors
Mm-hmm.
such as maybe the use of herbal medication, herbal concoctions,
Mm-hmm.
and then also exposure to heavy metals like the mercury, arsenic from the galamsey,
Okay.
and of course the use of over-the-counter pain pills, brufen, diclofenac, and the like. However, these seem not to be enough to explain the excess risk of the kidney disease that we have in our part of the world, especially the fact that they are affecting the very youth of our society.
Right.
So they have been digging to find out whether there is a background genetic predisposition to chronic kidney disease. As I said earlier on, this research was originally conducted in the US,
Mm-hmm.
and the gene was found to be concentrated among the African American population.
Okay.
So the thought was, okay, to conduct this research also in Africa where the blacks actually live,
Mm-hmm.
and find out if this gene is high in frequency in our part of the world as
Okay.
well. And therefore, when we conducted the research, we found out that yes, there's high frequency of these genes in our part of the world. Particularly, our research was concentrated on Nigeria and Ghana.
Yeah.
So that's why we can provide data at this point in time. But if I may give a background to how this gene came about.
Mm-hmm.
So the gene developed as a result of our exposure to infection by fly bite, trypanosomiasis.
Right.
And therefore, which normally gives sleeping sickness. But the gene developed over time in order to prevent us or protect us from developing sleeping sickness.
Okay.
Now, even though we may not be developing sleeping sickness because of this gene, our exposure to the fly and the resultant development of the gene increases our risk of developing chronic kidney disease.
Right.
So the genes, when you have two variants of the gene, your risk of developing chronic kidney disease is high. They are variants of the gene.
Okay.
You have G1, G0, G1, G2, etc.
Okay.
So if you have, say, a combination of, say, G1, G1 or G2, G2, then your risk of developing kidney disease is very high.
Okay.
Those who have the one risk allele like G1, G0 or G2, G0, they have low risk. In the past, their risk of developing kidney disease is low, probably non-existent or not published, or not much was said about it. But from our research work, we found out that even the one variant increases your risk somehow of developing chronic kidney disease.
Right.
Yes.
Okay. Folks, if you just joined us, 18 minutes past the hour of 2 on Joy 99.7 FM.
Joy 99.7 FM.
The program, as usual, is Ultimate Health with me, Nortey by nature. I'm in the awesome presence of Professor Vincent Boyma, Professor of Medicine and Nephrology. Recently done his inaugural lecture as a full professor in these domains, and he's mapped out, in fact, shed light on the path towards comprehensive, in fact, he uses the word holistic, right, precision kidney care in Africa, right? And he's just been sharing with us that there is a documented, verified empirically genetic biomarker, right? Something that you and I may inherit, which predisposes us or heightens our risk of developing kidney disease. Take your time, okay? So these biomarkers have been traced, and his team has been able to confirm their, presence, right, in the sub-region. The study covered Nigeria and Ghana. So they've been able to map this, and not only map the gene, they've even been able to show parts of the country in which, it has a higher presence. That's not related directly, but it's also part of the work, the wonderful, illustrious work they have done. Now, when you possess any of these markers, it heightens your risk. If you have multiple of them, then the risk escalates again. Okay, so that's one side of it. Now, the study also went further to look at the impact of kidney disease on the mind, right?
Yeah.
So he's looking at, harnessing all these new or relatively new awarenesses into management of kidney disease in Ghana and indeed Africa. That's what we're looking at.
Yes.
Okay, so stick and stay with us. We're plotting gradually. Now, Prof, so we know this, let me call it a diathesis, right? A predisposing factor.
Yes.
Okay, you've identified it.
Yes.
And again, what happens to the load when it comes to chronic kidney disease in our country? Because I've read papers, and even parts of your paper suggest that the key drivers known were the diabetes, hypertension, and so on and so forth. Taking your paper, does this change much?
I don't think so. I think there are multiple factors contributing to the development of kidney disease.
Okay.
So I mentioned some risk factors earlier on. Now we talked about genetic predisposition, which seems to be explaining the excess risk of this kidney disease in our part of the world. So factors may be working together to damage the kidney, not only one.
Okay.
So for instance, you have the genetic predisposition, and on top you have other exposures from the environment.
Okay.
Or perhaps from hypertension, or perhaps from infections like HIV, for instance. That multiplies your risk and therefore increases your risk of developing kidney disease. Now, we also said in our paper that having the two risk variants does not necessarily mean that you will develop the kidney disease.
Okay.
So that brings in the idea of a second hit hypothesis, meaning that, okay, if you have the risk variant, and you are exposed to certain agents that can trigger the overexpression of this gene, you may actually multiply your risk of developing the kidney disease. Okay. So both what is inherent within us, the genes, and what we are exposed to in the environment may be working together to damage our kidneys.
Okay.
Yes.
Right. Now, Prof, in your paper also,
Mhm.
you give a sense, of course, justifiably, of the burden
Mm.
in Ghana of chronic kidney disease.
Yeah.
Okay, I see a prevalence of 13 and above percent of adults.
Yes.
What does it mean for us as we listen
So
to you?
what it means is that 13% of people in Ghana may be living with chronic kidney disease.
Mhm.
Ghana's population is around 35.5 million.
So we're talking about 5 million
That's
plus.
close to 5 million people may be
Right.
living with chronic kidney disease in Ghana. That's what it
Wow.
means. Yes.
Right.
Mhm.
And we've got that burden known.
No, and sadly, it's affecting the youth of our society. The very young people who are supposed to be out there working are the ones who are being held down by this disease.
Okay. Now, when we start to
Mhm.
move forward to harness your research, and indeed there were many other co-researchers and collaborators,
Sure.
I think is even
Absolutely.
we'll mention them in a bit.
Yes.
When we move forward,
Mhm.
what is the path you and your researchers are suggesting that now we couple this genetic knowledge,
Mhm.
right, and genetic trace we are aware of.
Mhm.
So if, for example, I, Nortey, touchwood, I
Mhm.
have hypertension,
Mhm.
right,
Mhm.
and I have any of these genetic risk factors or predisposing factors you are
Mhm.
talking about,
Mhm.
then what? Should I be looked at differently in managing
So-
my kidney disorder?
Yeah, so usually in every disease condition, we look for the risk factors, underlying causes, and treat them. And
Okay.
that is the precision medicine we're talking about. You look for what is causing the disease, and the disease, target it exactly to treat it.
Okay.
So we screen you if you have hypertension, for instance. Let's say in addition you have protein, for instance, in the urine.
Okay.
We screen you and found out that you have this gene.
Okay.
Then, number one, we are going to target some treatment, either treating the blood pressure, giving you medications that treat your blood pressure, at the same time target the protein excretion in the urine.
Okay.
Then also currently there are research works going on, the clinical trials, trying to find out if there is a drug that can inhibit the function of this gene.
Okay.
And that has actually been conducted somehow in the US. Publication has been done to show that there is a drug that can actually block this gene
From
with-
expressing itself.
from expression itself, and therefore reduce the protein excretion in the urine by almost 47%. That's been published already.
Right.
So that's clinical trial has been replicated again in multiple countries, and we are actually one of the clinical sites in Ghana here now, which is ongoing. So if this drug works, we have a chance of actually slowing down the progression of kidney disease among our people, and then giving them a meaningful time of dialysis, of getting transplant, etc. So it's all about identifying risk, treating the underlying causes, and in this case, the gene becomes the cause of the problem or the significant part of the whole problem. There may be a gene therapy hopefully in future that can actually be helpful and actually decrease or slow down progression of kidney disease.
Right. If you just joined us, 25 minutes past the hour of 2 on Joy 99.7 FM. The program is Ultimate Health, your ultimate guide to healthy living. This and every Sunday, 2:05 with me, Nortey by nature. We are in the company of Professor Vincent Boima. The last time I had him here, medical school was celebrating its 60th anniversary, and indeed, I engaged him on was it young people failing kidneys? I
Yes.
think that was the title
Yes.
that was the tag we gave to it, right? Young person's kidney control, right? And kidney disorder, okay? And those of you bugging Prof on his phone, please, he's in the studio, okay? But that was 2022.
Yeah.
And you're saying we still have a concern about young persons affected by kidney
Mhm.
disease.
Yeah.
Right. Does this gene, or according to your study,
Mhm.
account for this, should I say, profile we have?
I think so. If you have the gene already, again, it means that you already have a background predisposition.
Okay.
And on top, you add other factors which actually further worsens your risk of developing kidney disease. So I would say that it's a combination of factors, both the genes and environmental. So there's interaction between these genes and what you are exposed to, which further increases our risk of developing kidney disease. In our part of the world, we often say, oh, maybe it's the environment. So the herbs we are taking, the bitters we are consuming, the aphrodisiacs, etc., the indiscriminate use of all these over-the-counter pain pills, in addition to all the other occupational exposures that we have, maybe the thing. But now that we've become aware of this gene as a possible explanation for the excess risk that we have in our environment, it's likely an interaction between the environment and our genes, which probably increases the risk of developing this kidney disease. That probably is a plausible explanation why these young people are being afflicted compared to Europe. For instance, where most people are above the age of 60 years. In fact, I was telling somebody, I was in a conference in Japan recently, and the average age of the dialysis patients was 70 years.
Wow.
So meanwhile, our people are between the ages of 20 to around 50, 59 years. So relatively young.
Right.
Yes.
And the sad part is, of course, dialysis is not a cure, right? It's an intermediate intervention, right? Which means that your kidney is harmed, and now we are helping it do its work, essentially.
Precisely, yes.
And listeners, coming up, I'll be discussing with Prof because he does suggest that, yes, the, should I say, shift to transplants should be something we're looking at. We do know that we have an organ donation kind of bill or law or legislation that would help us harvest, if I can use that word, and Prof will correct me shortly, but harvest functional organs from deceased, sometimes accident victims, and so on and so forth. But we need a legislation to prevent this being abused.
Yes.
Right. So I'll be coming to that. Right. But come back to this. So now what Prof is telling us, and Prof, what you're saying is that there is something that can suppress this gene and its activity and its expression.
Right.
So if it is a significant contributing factor to kidney disease, we can almost put it on mute, vibrate only.
It will slow down the progression of kidney disease, but it may likely not stop it completely. But for instance, if it's going to take you, say, 4 years to progress to kidney failure needing dialysis, for instance, it can take you 10, 15 or more years before you ever get there. That's the meaning of slowing down progression.
Okay.
Because every chronic kidney disease, when it starts, eventually it progresses. But how long you keep that person from needing kidney replacement therapy in the form of dialysis or transplant is really the idea of the delaying progression of kidney disease.
Okay.
Yes.
Right. So we can slow it down, gives us more room to do more good work.
Precisely.
Okay. I haven't brought in the mind yet. You know me as a psychologist. I'm happy you brought in the mind, and I see you have collaborators who are in the mental health field. Was it Prof. Matikole?
Yeah, Professor Christopher Charles Matikole, yes.
Right.
Yes.
Okay. So you also looked at how all this
affect the mind, yes.
Affects the mind.
Right.
Why was this important for the research?
So, chronic kidney disease affects other parts of the body, including the heart. So, for instance, number one cause of mortality among our patients is cardiovascular disease in the form of heart disease or stroke. But they suffer from other comorbid conditions, notably the mind. So, the chronic illnesses such as hypertension, diabetes, chronic kidney disease itself, in fact, other comorbid conditions, stroke, heart failure, all can affect your mind because of the long-term nature of the disease itself. Yeah. So, for instance,
the burden of chronic
illness. Yes. For instance, the people, they have a sense of loss of control. Yeah. They are no longer in control of their life. Something else is now controlling their daily life, which is the chronic illnesses. Going to the hospital, taking medication, having to abide by some kind of restrictions, etc. All these things really affect their mind in the long term, which increases their risk of psychological problem. For instance, complex medication regimen, abiding by all this, being hooked to kidney machine in the long term. All these things increase their risk of mental health. And the most common mental health they suffer is depression. So when we did this research among hemodialysis patients, 45% of them have some depressive symptoms. And then we found out that in addition, they have 20% of them have poor quality of life as a result. This, in the long term, affects their adherence to medication. So, for instance, they may not be able to take their hypertensive or diabetic medication as prescribed, and they have a worse outcome because of that.
Okay.
When they see a worse outcome, it can further worsen their mental health problems. So this can really become
cyclical.
a vicious cycle.
Right.
Absolutely.
Okay.
Yes.
Folks, you're hearing all this on Ultimate Health Joy 99.7 FM. 32 minutes past the hour, sharing good time with Professor Vincent Boyma, a product of the University of Ghana Medical School. No stranger to me, no stranger to the program. Indeed, when I had him in 2022, one of the things we were sharing was his cohort, his year group, and the fact that they've stayed. They've stayed here. I know you traveled to Stellenbosch, South Africa. To further your studies, and now as a full professor, I do know that you are a fellow of both the South African and the Ghanaian colleges and so on.
Yes.
Right? Share a bit about that with us.
So
from Bishop Herman, of course.
Yeah, Bishop Secondary School.
If you don't mention this, you're in trouble.
So 2 years as an A-level student in Bishop Secondary School, and I came to University of Ghana. So biological sciences, went to medical school, finished medical school, started residency, and then after that went to Cape Town for nephrology for 2 years, and then came back home.
This urge to come back home, explain it to me before we get back to the nephrology.
So I number one, I think that I never went to South Africa with the intention of staying. So it never crossed my mind to stay. That's what I would say. I really always want to come back home. Number two, I have been sponsored by International Society of Nephrology, and the International Society of Nephrology, their intention is to build capacity where you are.
Right.
So you have to come back and help. And those who supported me for this training, then Dr. Charlotte Otafo, Dr. Jumwa Edu, their intention is to build capacity home.
Build capacity.
So come back and help.
And a clear succession plan.
Exactly. So I think that these were the push factors that really, for me, brought me back home. I know people I went there with who were from Nigeria who never went back home. They don't want to go back home. But I intended to always return, so I came back home. Yes.
God bless you, Prof. Your medical school cohort is, so that should be in the late 90s, 97?
No, 2002, 2003.
Rather?
Yes.
I've gone backwards.
Yes.
Okay. So 2003, you finished medical school.
Yes.
Then later you got the sponsorship to go to Cape Town.
Yes.
Right? You did your nephrology. You came back.
Yes.
Now, let's gallop forward. Currently, we have a state-of-the-art nephrology center in Kolebu. Right? So not only do we have gems like you, jewels like you, right, contributing, helping improve quality of life, quality of care and all that, but we have a facility that allows us to do a lot more.
Yeah.
Speak a bit about that.
So the Nephrology Urology Center is a center of excellence.
Right.
And has potential to offer a lot of services in urology and nephrology. So nephrology has to do with kidney diseases, and we treat various kinds of kidney diseases, not only the ones who are on dialysis. So kidney disease, CKD, for instance, in stages 1, 2, 3, up to 5. In the early stages, we treat them, like I said, to delay progression, so we see them at the OPD in the new center. And then also, of course, those who progress to end stage will now have what we call kidney replacement therapy, which is in the form of dialysis or transplant. So in the center has 30 dialysis units.
Okay.
Machines. And then also a transplant service in that center. Theater has been built to be suitable for kidney transplantation. That's the main reason of housing both urologists and nephrologists in the same building, because of this particular collaboration to develop a transplant program going forward into the future. So all the patients who we see are potential transplant patients because they are all very young people. Their whole idea is, okay, once we are under that roof, the transit point really for those on dialysis especially should be to get a kidney transplant.
Okay.
So being in that building is strategic in terms of building a transplant program, in terms of providing high quality, state of the art service to the public. Yes.
Okay. Right. This one says, "Good day, Nortey. Kindly ask doctor if it's okay for a patient who is diabetic and living with only one kidney to do daily 30 minutes exercise and also continue to eat the same size of meal he used to when he had both kidneys functioning alongside the intake of diabetic medicines." This is from Prosper in Dakuman.
Yes. So you can have one kidney. It doesn't matter. It doesn't prevent you from exercising. You can do your daily exercise as it is because it's needed also to delay progression. So 30 minutes a day, 5 days in a week as recommended, you can do your normal exercise, but it should be done commensurate with your exercise tolerance level, not way and above what you can tolerate. And you should choose a form of exercise that you love, you can also always go back to and can sustain in a long term. So there's no reason why you shouldn't exercise. Lifestyle modification is a key part of the delaying progression. And the diet you talked about is also a key part, which is like key part of the lifestyle modification. So we talk about more fruits, more vegetables, less carbohydrate, protein in the form of, say, more white meat than red meat. And we talk about protein about 0.8 grams per kilogram body weight per day. But I'm sure dietitians can help you to quantify how much this is. Okay. And of course, decrease your salt intake, etc. All these are really very important in delaying progression of kidney disease. We also say avoid intake of toxins that affect your kidneys. Avoid the herbal medications as much as possible. Avoid unnecessary intake of over-the-counter pain pills like Brufen, diclofenac, naclofen, naproxen, Indosil, over-the-counter APC, etc. All these that can affect your. So it's all part of the management. Yes. Okay.
Right. This one says, "Blessed Sunday, Nortey by nature. Can you please ask Prof, he and his fellow medical professionals, do they have any plans of impressing on the ministry to embark on a nationwide campaign on protecting the kidney? I was at the Urology Center of Excellence, Kolebu Teaching Hospital last week and felt very broken looking at the number of persons who have to come for the dialysis clinic. The overuse of painkillers, alcohol, cigarettes, etc. To Prof, please tell him I'm also Bobu. I completed O-levels at Bishop Herman College in 1994. This is from Prosper in Dakuman. He's your mate?
1994. That's when I also completed.
Prosper, we have to do something. I keep on saying I have to meet Prosper, but today, dear, it has to happen soon. Yes. So Prof is your mate. So you are an associate professor. Okay, Prof. Now, your should I say milestones are important for me here. If your cohort is 20 or early 2000s, right? Yes. You've qualified, you are now a full professor. Share with my listeners, what has been the change in the outlook for a person suffering from chronic kidney disease over the years to the point where now we have a center of excellence and perhaps more capacity? What has been the change? What was it like at the time you were training as a medical student? What was the outlook for the average, person suffering from chronic kidney disease?
So that's a very important question. So at the time we're in school, we have trainers and teachers, very renowned people. The late Professor Kwame Afram of blessed memory, Professor Michael Matekole, very renowned, prominent, very intelligent man, so knowledgeable. And they had a chronic kidney disease clinic. They had a clinic for kidney diseases that have been managing people regularly and seeing them. All of us rotated through those clinics when we were in training. And so that's how they detect people and then they treat them to delay progression at the clinic those days. And then also at the time, let me say that dialysis is more than 50 years in Ghana now. The first dialysis machine was in 1970 or 1972 with Professor Matekole, Professor Dr. Nim, I've forgotten the name very well, but they were in charge those days. And it was because one patient from Valco, those days Valco, had acute kidney injury, needed dialysis, and then they didn't have one. So I think the Valco provided the machine. That's the first machine they started with. And then they had the dialysis machine. Those days, one machine that they
machine.
used to use those days in 1970s in Kolebu. Subsequently, the machine numbers increased over time in Kolebu. And then we also have a number of other dialysis centers springing up at the Cape Coast, Kumasi, and then now dialysis is widely all over. In fact, where now we have more than 55 centers now.
That's public and private.
Public and private.
Yeah.
Now mostly private. 67% is our private now.
Right.
That are offering dialysis services. And however, there are still 7 regions though without dialysis. So I must say we have come very far in terms of providing dialysis services. Transplant was not there until 2008 when transplant started. Now it's becoming a bit more regular. It's being performed even at the Bank Hospital, UGMC as well.
2023, I think.
Oh, we are now. It's a bit more regular. In fact, we did last year, for instance, I did 3 or more 4 occasions we've done transplant. Now we've done one already this year. The next one is next month. So it's now more regular than it used to be. So we have come far in terms of kidney replacement therapy. We have come far in terms of the services we offer to patients, both in delaying progression, both in terms of also providing kidney replacement therapy. In terms of the education bit that the young man talked about, and it's also key, but we've been doing that from the Ghana Kidney Association point of view, where we celebrate the World Kidney Day every year, and we go out there to educate people, do free screening and educate people. And that has been going on for long, even before I came back from Cape Town. It's still ongoing.
Right.
But I believe that our education is not reaching the hinterland, the very districts. So we probably need a government machinery that can enter those nooks and crevices and give more information. Can we use, for instance, community healthcare nurses who are in the communities, community pharmacists, community champions, and train them who can carry the message, etc. I think this is where we are now, to really use a system that can reach far in terms of the information we give out. So it's a very good advice from a questioner, and I think that is something we need to look into.
Okay.
Yes.
Right. Prof, looking again back to your paper and the illustration or the picture it paints, right? Close to 5 million Ghanaians could be living with or affected by chronic kidney disease. Right. I doubt if we are anywhere near meeting that demand, right? We've got astonishing academics and clinicians like yourself in the scene. What else do we need, really? I know the private sector has come in significantly to help us in Kolebu and other parts of the country, across the country indeed. What else do we need significantly to change and to add?
So I think historically, as you know already, dialysis was not covered, for instance, by National Health Insurance. But I saw recently that they have some coverage. So I think things probably may be turning around and giving more people a chance to get treatment, because hitherto probably less than 10% of people could afford. But now that could increase if National Health Insurance came in. I must say, even before we mention National Health Insurance, there's First Sky group of companies who over the years have been supporting these patients.
They've been phenomenal.
Paying for their transplant, paying for
but they always
dialysis.
Avoid media coverage.
They don't like coverage. They don't like
them.
Yes.
God bless them.
They don't like publicity at all. Yes. So they've been paying for over 9 years. They've paid more than 50 million Ghana cedis towards transplant and dialysis for these people. And for them, because of them, people are living for long in this country. People have lived for 5, 10, or 8 years purely because of their benevolent service. So I think that what the government is doing now is timely and welcome. Is something that we're all praying for. Now we are seeing it, and I think this is largely going to complement what the First Card Group has already been doing to increase the treatment service to people. Let me say life-saving treatment to people who need it. However, I would say that for these young people in Ghana, transplant should be the ultimate.
That should be where we should
because
be heading.
Because number one, lifespan is better. Treatment satisfaction is better. Convenience is better. Quality of life is very much improved. In the long term, it turns out to be more cost effective than even dialysis itself. So it should be the way we should be going. And transplant, like I said, started in 2008, has improved over the years. So we hope that
What kind of numbers are we looking at currently for transplants in Ghana
in Ghana,
by Ghanaians?
By Ghanaians, I think that they've done in total, it should be more than 50, 55, or probably 60 transplants more
Okay.
than that is. If you add the private sector and all that places, it's much more. But we need to collect our data to really give you
Okay.
accurate figures. But there's a need for us to develop the transplant system further. What we are doing now is currently what we call living-related donor
Donors.
transplant. So you need to find
Your
a
relative?
kidney donor from relatives from the family to give you a kidney.
Okay.
But to expand it to what we call disease donor, where we can get organs from us dead or dying people to give to people who need it, we need legislation to cover all that. And I think that legislation is currently underway, and probably now we'll say we can see some light at the end of the tunnel because discussions have started
Okay.
actively to hopefully bring this out finally to cover the transplant activities in the country.
Let me work on that light at the end of the tunnel because I do know a bit about this. But typically, maybe even culturally, as Africans,
Yes.
when it comes to the body, organ donation and these kinds of things have met with a lot of resistance. Now, explain briefly, if you may, for my listeners, why do we need a legislation? Nortey has his body. He says he's donating it to the medical school. I think that is already permitted, right? So that when he's no more, whatever works on his body can be used to help save or improve the life of somebody else. What is the legislation seeking to address and control?
Yeah, there are ethical issues, and the whole system can be abused,
Yeah.
and there could be criminal cases as well. So we need a law backing this. For instance, if somebody goes to sell an organ to another to a patient who needs it, that is illegal. That is unethical. And there's a need for a law to back that. So those who do that can be questioned appropriately because it's unethical to do that. You're not supposed to pay any money for any organ.
So we are not talking about buying and selling organs.
No, it's not. It's unethical to do
and
that.
the law will and should prohibit
Prohibit
and
that.
make sure.
Absolutely. Imagine we allow that to happen.
Right.
There will be trouble. People will be killing people.
Yep.
Because of money. You've heard about things that people trying to cross the desert into Europe.
Yep.
Some have lost their kidneys, etc. These are criminal things that are going on elsewhere.
So the legislation,
is needed really to make sure that this doesn't happen.
Thorough
Proper and thorough legislation is needed. And then if it comes to the disease donor, even more so because the disease donor organ transplantation should be done in a way that is fair and there's justice. And then whoever needs the organ gets it. Because when the organ becomes available because somebody is dead or dying, let's say literally it's a state property at that point in time. The person has offered to donate. He's already giving consent before he dies. So by what
system do you allocate that organ?
So system should be in place whereby there will be what we call a waiting list.
Exactly.
Operated at the national level, where they can look at the list and say, okay, the next person on the list who is compatible with this particular donor is so and so, and the person is in Kumasi or in the north. They will call the person to come for the organ. So that it's not abuse.
It's not who you know business.
It's not who you know business.
Right.
Exactly. Yes.
Okay. So, folks, you're hearing all this in my engagement with Prof. Vincent Boima, Professor of Medicine and Nephrology, Head of Medicine and Therapeutics at the University of Ghana Medical School, illuminating the path towards comprehensive precision kidney care in Africa. This is interesting and it opens many, many other discussions. Currently, there are people on dialysis where a machine takes up the functions your kidney is unable to perform. Right? Yeah. How many people do we have on dialysis in Ghana?
So I think we published a data in 2017. That's very old, and we said about 600. But trust me, that's under collection because we collected data from only 5 hospitals at the time.
Okay.
So he didn't.
And these
collect
were public facilities.
and these were public facilities,
not
we didn't
private
collect
facilities
exactly.
that are
So if you, from my estimation, it's more than 2,000.
right.
If we really have to collect the data now, it's far more than 2,000 people. And actually, these are the people who have access to it or can afford.
Right.
That means there are a lot of people who need it but are not getting it.
Wow.
Yes.
Okay. And these are also people who potentially might require the dialysis. What is it? Once weekly?
So it's ideal treatment regimen is 3 times a week.
3 times a week.
Yes.
At what cost, Prof?
So right now in public centers, it's between 600 to about 850 Ghana cedis per session.
Per session.
So that if you are doing 2 or 3, it multiply by 2 or 3. And then in private sector, it could range from 1,000 to 2,000
right.
per session. If you look at it clearly, that's a lot of money per month for the average person who is on dialysis.
Okay. Now,
Yes.
Prof, if I suffer from kidney disease and I require dialysis, right? And now you've broken it down to CDs and pesos, seriously.
Yes.
And I miss a dialysis. What
Session.
exactly is happening to me or likely to happen to me?
So
Because many people now have to do their calculations. I'm supposed to go 3 times a week, but I go once.
you're not going to receive adequate treatment.
Okay.
Because when your kidneys were functioning, the kidneys were functioning every minute, clearing at least or cleansing at least 60 or more mils of your blood every minute around the clock.
Okay.
That's how the kidney is cleansing your system. That's how efficient it is. Even compared to the dialysis machine, it's nothing compared to the dialysis machine. The kidneys are far more efficient than the dialysis machine. But 2 or 3 times per week are found to be compatible with life.
Okay.
So when the doctor prescribes 3 times a week, that is what is required. That is what will keep you healthy and stable.
Okay.
When you are doing once a week or once a while, you are not clearing the toxins and fluid well from your system. And therefore, you will not feel well.
Right.
And your survival will be lower, your quality of life will be lower, your functional state will be really poor compared to somebody who is doing it efficiently according to prescription.
Okay.
Yes.
Right. 54 minutes past your hour 2. This is interesting. Nortey, please give Prof my contact so I get to meet him when I go for my clinic day at the Center of Excellence. I was popularly known as Bob Otoyo in St. Maurice House, House 5. Bob Otoyo wants to meet you, right? When he comes to the Center of Excellence, right? I'm not too sure. Well, okay, I guess that suggests this is still Prosper, I think. All right. He wants to meet you, so I'll see how I can connect the two of you. Okay.
Right.
But again, Prof, last time when we had to discuss support and provision of sponsored, if not free dialysis, especially by the NHIA and all that, it came to light that the sponsored brackets were not the age groups that had the numbers, right? Though they were providing the sponsorship for the free dialysis. I'm in contact with the kidney, the Dialysis Patients Association.
Yes.
Right. The spread seemed to look at where the numbers are lower and those in the areas of concentration may not have been adequately addressed. Is this the case?
That was when they were piloting it.
Okay.
But after that, they went later down they declared it free.
Okay.
So it opened up. It's no longer age group dependent.
Okay.
It changed.
So
they
there's cover across the spectrum.
Yes, now it's covered. It's no longer limited to any age group now.
Okay.
Yes.
So if you have kidney disease right now and you require dialysis, it's covered.
Yes. So
Across
those
the country.
who go to Kolebu, the Center of Excellence, they are not paying.
They are not paying anything.
No.
At all.
No.
Right. Nobody is paying anything.
Nobody.
Irrespective of
we
age.
used to irrespective of age. No, we used to have the issue. this program whereby those who work for the corporate institutions, the
Mhm.
banks, etc.,
Okay.
we told they should pay so that at least there's some generation of internally generated funds to maintain the place.
Okay.
But I think it really was creating problem between those who largely were not paying and those who were paying. So that program has been scrapped as well. So everybody pays, and this is something we used to do long ago, even before the NHIS came. So it's
Okay.
not something that is new. The corporate people were always paying for their people,
Okay.
and that's really where we get money from to maintain the whole place.
Okay.
I mean, to going to cover for those who are not able to pay as well.
Okay.
So now that insurance is there, when you come to our center, it's supposed to be free. So nobody is paying.
All
Yes.
right, that's good news. You're hearing from Professor Vincent Boima, Professor of Medicine and Therapeutics, talking to me, Nortey by Nature, on Ultimate Health. Prof, again, there's a lot of advocacy that you've been doing over the years, right? We're looking at the numbers, and you're, shedding light on comprehensive
Yeah.
precision kidney care. So, what is going to change? Is just more hard work from professionals across disciplines like you and your colleagues? What is the template you would like Africa to adopt?
So thank you very much. Now, if you have my own opinion, I think we should go to the community
Right.
and sound the bell to prevent kidney disease.
All right.
That's what we need to do.
Let's prevent it.
Prevention.
We don't
would
want to get
decrease-
to
Yes.
care.
Prevention would
Mhm.
decrease the burden.
Okay.
Prevention would decrease how much government is going to pay for the care of the patient.
Mm-hmm.
Prevention would decrease how many people trickle in to be on dialysis, to increase cost burden for both families and the nation.
Okay.
And of course, those needing transplant. So
Mhm.
going out there to tell the people, hey, stop drinking what you are drinking. Good lifestyle modification, catching the hypertension and treating it early, catching diabetes and treating it early may help to prevent kidney disease.
Okay.
That's one. Number two, catching the kidney disease itself very early in the early stages,
Okay.
like 1 to 3, and then linking them to appropriate care in the community health centers.
In those early stages, Prof, let me just interrupt. In those early stages, are you still delaying progression, or are
Absolutely.
you curing?
No, you are delaying progression. Every chronic kidney disease eventually progresses.
Okay.
You can only delay how fast it takes to get to kidney failure.
Okay.
Yes.
Right. And the dialysis is helping in doing that, but you emphasize we should be
Prevention,
heading towards,
Early diagnosis, prevention, early diagnosis. That is the key.
and in the absence of that, we should be doing transplants.
In the absence of that, for those who progress to kidney failure, we should be doing transplant to actually decrease the number of people who are staying on dialysis.
Okay.
And actually, it's important because we can reintegrate all these young ones back into society.
Okay.
Yes.
Right. Prof, there was one I skipped. Somebody wants to know, what if both kidneys fail? What happens to such a person? They
Anytime-
understand that you can live on one kidney,
Yes.
but what if both fail?
No, anytime you are diagnosed of kidney failure, both have failed.
Okay.
That's it. So kidney failure, both of kidneys have failed. That's what it means. If one was working, your kidney function will be relatively good or even near normal.
Okay.
So if your kidney one is working, your kidney function test will not show us signs of kidney failure or signs of kidney disease.
Okay. Right. And lastly, we're out of time, but with this genetic predisposition, this genetic marker,
Yes.
right? You obviously were doing a clinical research,
Yes.
right?
Clinical
and,
trials.
and then have published,
Yes.
right? You've published your paper.
Yes.
Yep. But if I'm listening to you now and I want to know, please, Prof, do I have it? Is there any procedure, any
And the test.
way or test that
Yes.
shows that I have this gene or genetic biomarker?
Right. I think that the screening tool or test kit would become available in the near future. Probably not in Africa, but in other parts of the world. I think they have a diagnostic kit that they can use to screen people more easily than we are doing. What we are doing now is that because of the clinical trial we are running in Kolebu, we take advantage of that clinical trial to screen people, because we are recruiting them to see if they have the genes
Okay.
for the trial.
Okay.
So when I see somebody where I think, may have it on account of clinical background or history, I refer the person to the clinical trial center, and then they test them for the gene and all that. So in the interim, it's not routinely available for screening the people at the OPD, but I guess this is where we are going because this is where the gene is. Yes.
Okay. We're out of time. Prof, we're so proud of you. I'm sure Bishop Herman is proud of you. That was sixth form. So
Yes.
what did you do?
So I lived in the T region with my parents. So I attended KJB Secondary School, and then from there I moved to Bishawan.
Wow.
Yes.
Thus far has he brought us.
Yes.
Prof, I salute you today.
Thank you.
I know I bug you a lot because people want to know certain things. You are pretty slippery for good reason. But today I caught you. But I want to catch the private sector part of this later with you because they
Sure.
also do an immense, tremendous
Absolutely.
part of the heavy lifting when it comes to kidney disease.
Right, absolutely.
Once again, it's lovely to call you Prof. I've been
Thank you,
doing
my
it over
boss.
there.
I call you my boss.
Oh, I beg you. Prof. Vincent Boima, congratulations and thank you for lighting the path. And I hope Africa will gradually get there when it comes to these conditions. Stick and stay on Joy 99.7 FM. Indeed, we did bring the best. I'm going out, but stick and stay.